Chairman-elect Dr. Rajshekhar C. Jaka, all the executive committee members, all the surgeon colleagues, teachers of various institutions, and my dear students. Today is the second PG time of KSCASI, and we have two important topics. One is carcinoma penis, which is being presented from by Dr. Afsar from Kanachur Institute of Medical Sciences, and the second case is the obstructive jaundice by Dr. Varsha from KMCRI Hubballi. Wishing you both all the very best. And we have Dr. Gopinath Pai from KVG Medical College, Sullia. And just to remind all of you that we have this MidCon at Sullia on 8th and 9th of August. We welcome you, sir.
Thank you, madam.
Yes, we have Dr. Likith from Kanachur Institute of Medical Sciences as a second examiner. And we welcome you too, sir. And Dr. Anand Kumar will be moderating this session. Dr. Srinivas Pai has expressed his inability to attend. So I asked Dr. Anand Kumar to moderate this session and requesting all of you to post your questions in the chat box. Thank you. Over to Dr. Sarvesha. Thank you, one and all.
Thank you, madam.
Hello. Thank you, madam. I welcome all consultants and EC members and PG students to this PG time. First case, we have a carcinoma penis by Dr. Afsar, Kanachur Medical College, PG. Dr. Afsar, please start the presentation.
Afsar?
Yes, sir. Yes, sir. Presenting, sir. Good evening, everyone. Today, I am presenting a case presentation on carcinoma penis. Myself, Dr. Muhammad Asfar Hussain, final year postgraduate at Department of General Surgery, Kanachur Institute of Medical Sciences, Mangalore. My moderator and guide, Sir Dr. Likith M. Rai, who is HOD and professor at Department of General Surgery, Kanachur Institute of Medical Sciences, Mangalore.
Yeah.
73-year-old male, patient by name Mr. X, occupation truck driver from Bihar, presented with the chief complaints of wound over the penis since 6 months. History of presenting illness: patient was apparently healthy 6 months back. Then he noticed wound over the tip of the penis of size 1 × 1 centimeter, then later progressed over the next few months to the current size, that is 5 × 3 centimeters, associated with pain and bloody discharge. Pain is burning in nature while passing urine. There is associated discharge from the wound, which is foul smelling and purulent in nature. Initially scanty in amount, but now increase in quantity. Patient also gives history of passage of urine through multiple abnormal openings over the growth. Patient is unable to retract the foreskin after the appearance of mass in the penis. He gives the history of unable to retract the foreskin after the appearance of mass in the penis. Complaints of left groin pain since 1 month, which is dull aching type of pain and non-radiating in nature. No history of trauma, no history of hematuria, no history of weight loss or loss of appetite, no history of swelling in both the groin. Past history: history of high-risk sexual behavior, no history of previous hospitalization or surgeries in the past, not a known case of hypertension, diabetes mellitus, thyroid disorders, and tuberculosis. Personal history: patient consumes non-vegetarian diet, appetite is normal, bowel habits are regular, sleep is adequate. Bladder habit is altered with difficulty in passage of urine. Addiction history: history of smoking BD 5 to 6 per day since 10 years. History of consumption of alcohol occasionally. Drug and allergy history not significant. Family history: the patient has married for the past 40 years and has 4 sons and 2 daughters, of all of whom are apparently healthy. No history of malignancy in the family. summarizing my case till this one. My patient, a gentleman of 73-year-old, presented with the complaints of painful wound over the penis associated with purulent discharge for the past 6 months, and there is difficulty in passage of urine. There is history of high-risk sexual behavior and secondary phimosis. No history of trauma or hematuria. No history suggestive of distant metastasis.
So with, wait a minute. Before proceeding to examination, go to the first
Yes.
slide. Yeah, next. Yeah, next. You mentioned about wound over the penis.
Yes, sir.
So where exactly in the penis? Because you tip of the penis you told.
Yes, sir.
Yeah. So is it in the glans area or in the prepuce?
Sir, he told in the glans area, sir.
No. He told in the glans area, but you told there is difficulty in retracting the prepuce also.
Yes, sir.
Yes.
The growth, the wound was in the glans penis, sir, unable to retract the foreskin over it, sir.
Unable to retract the foreskin over there.
He gives the history of unable to retract, sir. At present, there was huge mass, sir, when I show the picture.
At present, there is a huge mass, 5 into 3 centimeters.
Yes, sir. 5 to 3 centimeters. Grossly, sir, when measured, it like I will tell in the inspection part, sir, it is 7 cross 4 centimeters, sir, approximately.
You mentioned in the history that there is a history of exposure to sexually contracted disease.
He's not history of sexually transmitted diseases, sir. He's a high risk sexual behavior. He gives a matlab like, sir, he has multiple sexual partners. This one, sir, partners, sir.
Partners, okay.
Yes, sir.
No groin swelling.
Yes, sir. Is there, sir? Left groin swelling, sir. Complaints of left groin pain.
No, you
since
told
1 month.
groin pain, swelling?
No, sir. No, not swelling, sir. No obvious swelling
No
noted, sir.
Okay. No history of retention of urine.
No, sir. No history of retention of urine, sir. He voids, sir, but he is complaining of multiple openings over the wound, sir. Over the growth.
Okay. Yes. Any other thing in the history regarding cough, hemoptysis?
No, sir. No, sir. No history of hematuria or cough, sir.
Okay. Right. Go ahead.
Proceed.
General physical examination. Patient was examined in a well-lit room with adequate exposure after taking informed consent. Patient is conscious, alert, cooperative, well-oriented to time, place, and person. Average build. BMI is 22.49. ECOG score is 0. Adequate hydration status. Pallor, icterus are absent. No cyanosis, clubbing, edema. Pulse rate is 80 beats per minute. Blood pressure is 110 by 80 millimeters of mercury. Respiratory rate is 18 cycles per minute. Temperature afebrile. Local examination. On inspection, patient is examined in supine position with adequate exposure of external genitalia, perineum, and both the groins under good lighting. An ulceroproliferative growth is seen on penis circumferentially extending from the tip of the penis to the root of the penis. Size measuring 7 cross 4 centimeter. The growth has irregular margins, everted edges. Floor is covered with slough, areas of bleed, and purulent discharge. External urethral meatus is not identifiable. Scrotum and perineal skin appears to be normal. No visible edema of lower limb. This is the photo, sir.
Yes. Looking at this, you think it's aggressive disease or mild disease?
No, sir. By looking at the disease, we can comment on it's an aggressive disease, sir.
Why? What makes you think that?
The lesion is very big and there are areas of slough necrosis, sir, at the central part of the wound.
The entire penis is involved.
Yes, sir.
Entire penis is involved, isn't it?
Yes, sir. Yes, sir.
Yeah, go ahead.
On palpation, no local rise of temperature, tenderness is present. An ulceroproliferative growth noted of size 7 cross 5 centimeter, extending from the tip of penis till the root of the penis. Surface is irregular, nodular, and firm to hard in consistency, with areas of dried slough or eschar noted. Edges are everted. Base is indurated and extending till the root of penis.
Till where is the induration extending?
Till the root of the penis, sir.
Okay, not beyond.
Not beyond, sir. Not.
Okay.
Inguinal lymph node examination, left side. Multiple palpable nodes of size around 1 cross centimeter to 1 cross centimeter are noted. Round to oval in shape, firm to hard in consistency, non-tender, mobile over deeper planes, not matted, no palpable lymph nodes on the right side.
Do you think these lymph nodes are significant? Not significant.
At this point of time, sir, like by seeing the wound photo also, like it may be secondary to the infection, sir.
Yeah, right.
It might be secondary
But
to the
what about the consistency? It is hard in consistency, right?
yes, sir, firm to hard in consistency.
Firm to hard.
If it is infection, usually it is not hard. It will be soft or firm.
Yeah, sir, yes, sir.
So you can't directly tell it is not significant at this point of time.
No, sir. You can send a FNAC of the.
No, that is later, Baba. This is clinical examination we are talking about.
Okay, sir. Okay, sir.
Yeah.
Soft.
No. Proceed.
Scrotum and testis. Scrotum is soft and non-tender. Bilateral testis and spermatic cords are palpable and normal in consistency. Digital rectal examination. Normal anal tone, no prostatomegaly. Glove finger stained with normal stools. Systemic examination, CVS, S1, S2 heard, no added murmurs. CNS, GCS 15/15, no focal neurological deficit. Respiratory system, bilateral AR&T present, no added sounds. Per abdomen, soft, non-tender, no organomegaly. Musculoskeletal system, no bony tenderness along the spine. Provisional diagnosis. This is a case of ulceroproliferative growth in penis, most probably malignant in etiology, with unilateral inguinal lymphadenopathy with no signs of distant metastasis. TNM staging, I would like to state T3N2MX.
Where can this spread metastasis? Usually it is lymphatic, right?
Yes, sir.
Okay. Hematogenous spread is possible?
No, sir, it is very rare, sir. Mainly by the lymphatic spread. It spreads by lymphatic, sir. It shares for the common lymphatic channels.
Okay. So
now looking at this and its history of exposure to multiple partners, you think
Yes,
it's
sir.
still an aggressive disease or something which is not very aggressive?
Aggressive
Despite
disease
having such a big lesion.
Yes, sir. It is, by seeing the lesion, a big lesion, like it is an aggressive disease, sir. By seeing like by taking a history of high risk sexual behavior and a truck driver, like by truck driver we can we can predict the poor hygiene also, sir.
No.
Pardon?
The question is whether it is aggressive or not. It is an aggressive disease.
Yes, sir.
Yes.
So, anything else, sir? How will you proceed?
What are the pre-malignant conditions of carcinoma of the penis?
Pre-malignant conditions, it is divided into two types, two subheadings, sir. Non-HPV related, HPV related, sir. Non-HPV related are cutaneous horn, balanitis, xerotica obliterans, sir. And HPV related are condyloma acuminata, Buschke-Lowenstein tumor, sir.
Okay.
Yeah. To which category this belongs?
Pre-malignant conditions, sir.
No. Yeah, I know. To which category? This is derivative of which one? Pre-malignant or post-HPV?
Post-HPV, sir.
Why?
Like the serotypes are like human papilloma virus 16 and 18 are the most common.
All right. Okay. Right.
Proceed.
Yes.
Any differential diagnosis?
Yes, sir. I can give a differential diagnosis. HPV, like human papilloma virus, sir. Like
No,
other.
you want to give differential diagnosis after looking at this ulcer and inguinal lymph nodes?
No, sir. No, sir. I'd like to
No.
like more consider as a CA penis, sir.
Any, if at all, any diagnosis is there? You want to give something?
No, sir. No, sir.
No, if you want to give, most welcome.
No, sir. By looking at the photo, like of the patient and all, like.
Okay.
Yeah.
Proceed.
Sir. Like.
What do you want to do? How will you manage this patient?
Sir, like first, I want to confirm my diagnosis, sir. First 3 steps, I would like to confirm my diagnosis. Second, investigation, and I want to do the staging of the disease, sir. Confirm the diagnosis by the biopsy, sir. Edge biopsy.
From where will you take the edge biopsy?
Like in between the wound and the skin, sir. Like junction between the wound and the skin.
Okay. Why not from the center?
Center part will be the more necrotic, sir. Like the more differentiation cells will be the at the around corner of the wound, cancer, sir.
Malignant. Around
Malignant. More cells invading to the normal tissue.
And the center is filled with necrotic tissues.
Necrotic, sir. Yes, sir.
Proceed.
First, I will confirm my diagnosis with the histopath biopsy report, sir. Then I will stage the
Squamous cell carcinoma.
Yes, sir.
What else you want to know?
And then, like, I want to know, like, stage the disease, sir.
No. Before staging, you want to know the grade, differentiation.
Yes, sir.
How many grades are there?
Grade 4, sir. Borders classification, sir. Grade 1, grade 2, grade 3, grade 4. Very well differentiated, moderately differentiated, and poorly differentiated, sir. Grade 1, 2, 3, 4.
Okay.
According to
you want to know in the biopsy? Nothing. That's all.
Yes, sir.
Okay. You want to send a culture from that?
No, sir. Biopsy is sufficient.
You are telling there is a lot of infection there.
No, sir. The second superadded infection will be there, sir. Like.
So you want to send a culture?
No, sir. No culture, sir.
Why don't you send a culture?
Biopsy is alone sufficient to diagnose, sir. Culture,
No. Biopsy is sufficient, I agree. But now there is a superadded infection also there because there is so much of secretions there, isn't it? If
yes,
you
sir.
operate or after surgery or before surgery, whatever, don't you want to put the patient on antibiotic based on culture sensitivity?
Yes, sir. Anyway, we are going to remove that the whole part, sir. No point of sending the culture, I think.
Which one? Then that means you are very sure about those lymph nodes which are palpable. Mere 1 centimeter lymph node are significant here.
Multiple palpable it was, sir. So
yeah, you told
every other individual barefoot walker will have larger lymph node, more than 2 centimeter lymph nodes. So that's what sir wants to tell you.
Okay, sir.
Arey Baba, it is better to take a culture. No, what is the harm there?
Sir.
Huh?
Okay, sir.
Yeah. Then
proceed.
So biopsy comes as a poorly differentiated squamous cell carcinoma. Grade 4.
Okay.
Yeah. Now.
Okay. Like next, I will stage the disease, sir.
Yeah. How will you stage?
By doing CCT abdomen and pelvis, sir. Contrast enhanced CT scan, abdomen and pelvis, sir.
Yes. Information.
Then, yes, sir.
You have
what
a
is the
CT
information
report?
you want?
Yes, sir.
What do you want to know? You told pelvis. Why you want pelvis?
More aggressive tumors, like after grade 3, grade 4, it spreads to the deep pelvic group of lymph nodes also, sir.
Okay. So it's a moderately differentiated squamous cell carcinoma. Grade 2.
Grade 2, sir.
What about lymph nodes?
Lymph nodes, In the CCT, we'll get to know about the lymph nodes, sir. The status of the lymph node, which group are involved.
Yes. What
After
are the
that,
groups of lymph nodes?
sir,
How are
group
they
of lymph
divided?
superficial and deep, sir.
Yes.
Superficial group and deep group. Superficial group, again, they have divided into horizontal and vertical, sir. Horizontal along the inguinal canal, sir, along inguinal ligament. Vertical along the GSV, sir. Superficial group lymph nodes are above the facial aorta with 25 in number. Deep to facial aorta, which are these ones are 5 in number, sir.
Yeah.
How will you
What do you want
confirm
to
the
do?
involvement of urethra?
Yes, sir.
How will you confirm the involvement of urethra is there or not?
I will do MRI, sir. Like
Is there something which is simpler?
simpler, sir. Ultrasound, sir.
What are the features of secondary deposits in ultrasound? What is the feature of a normal lymph node? How does normal lymph node look like, and how does a deposit look like?
Normal lymph node will be this one, sir. Like maintain fatty hilum, sir.
Yes, correct. Then
Maintain fatty hilum in this one, sir.
so when it is positive, can you do anything else with the help of ultrasound?
Ultrasound FNAC rates.
Yeah, you can do FNAC. Ultrasound get FNAC also. Can
Yes.
FNAC give you malignant cells?
My FNAC gives yes, sir.
Yeah.
Doppler?
Doppler, sir. Sorry, sir.
Doppler investigation, whether you do in this case or not. Arterial Doppler.
Arterial Doppler. No, sir. No.
Then how will you do the lymphovascular invasion? Histopathology, you told. You're not told, but lymphovascular invasion is there or not?
Lymphovascular invasion is there, sir, in this case.
Okay, that is there in pathology report.
No, sir. Like they gave only the moderated differentiated squamous cell carcinoma.
Biopsy is now lymph nodes are positive for malignancy. Moderation differentiated squamous cell carcinoma, and you say it is an advanced disease. What is the is there any length of staff which is not involved in the malignancy now?
No, sir. The whole shaft is involved in this, sir.
Whole shaft is involved.
Yes, sir.
Okay. How will you treat this gentleman now?
After getting CCT, sir, I will do all routine investigations, sir, for workup for the patient.
Yes.
PSC clearance. Then like total, I will consider this patient as total penectomy, sir. Total penectomy plus diversion perineal urethrostomy.
Why you want to say it is diversion?
Like the urine, like diverting. Perineal urethrostomy.
Yeah. So you say perineal urethrostomy.
Yes, sir.
Yes.
Perineal
Then
plus unilateral superficial inguinal lymph node dissection, sir.
why you want to do only unilateral?
No, sir. Based on that, I will send the sample, sir, for the frozen section. If they come as positive, then I'll proceed with the deep inguinal group nodes dissection also.
No. Sir's question is why only unilateral? Why not bilateral?
No, sir. Bilateral superficial inguinal lymph node dissections.
See, clinically, you are telling right-sided inguinal lymph nodes are involved. Okay, correct?
Yes, sir.
Yes. Left side, clinically, you have not got, but through CT scan or evaluation, imaging, if you get, you want to leave it there or you want to do something for that?
No. Both. If the CT scan is showing both bilateral inguinal lymph nodes plus iliac groups are involved, sir.
So you have to do a superficial lymph node dissection. Send it for a frozen section. If it
Yes,
comes
sir.
positive,
Positive.
go for a deeper dissection.
Yes, sir. Yes.
Any other blood investigation will do?
Any apart from the anesthesia clearance, sir.
Routine, yeah. Because you told high risk behavior, sexual behavior is there.
Yes, sir.
You have to do no HPV, HIV,
Yes,
PDR,
yes, sir.
syphilis, everything you have to do. First, that you have to do.
Yes, sir. Yes, sir.
No.
Okay.
What is this lymph node of Cabana?
Lymph node of Kumar are superomedial, sir. Deep inguinal group of lymph nodes which are superomedial, sir. In
Where is
between
it?
the yes, sir.
Where is it located?
In between the superficial epigastric and superficial external pudendal veins.
Superficial in the canal, no?
Yes, sir. Yes, sir.
Femoral canal, no?
Yes, sir.
I want to ask, you told about the lymph node dissection, correct?
Yes, sir.
Now, what are the complications following a lymph node dissection, ileoinguinal lymph node dissection? Before that, before going to that, what are the boundaries of your lymph node dissection?
Boundaries of inguinal groove node reception is the line joining between the ASIS and the pubic tubercle, sir. From the ASIS till 20 centimeter, the line extends downwards, and the pubic tubercle from there 15 centimeter downwards, sir. The line joining between these two, sir. This is the boundaries of the inguinal canal dissection, sir. Dresler's quadrangle.
It's a quadrangle.
Yes, sir.
What are the structures you remove?
Fibrofatty tissue in between these planes, sir. Entire fibrofatty tissue will remove, sir.
What is the boundaries of the femoral triangle?
Femoral triangle, sir, like medially by the medial border of adductor longus, sir. Laterally by the medial border of sartorius, sir.
Base?
Superficial.
Base
is formed by the adductor longus muscle, sir.
Base, man.
Oh, that is floor.
Floor, sir, sorry.
That is floor. Base?
Inguinal ligament.
Inguinal ligament, sir, sorry.
Okay, fine. What are the complications following this block dissection?
The most common complication is this one, sir, like flap necrosis, lymphedema, seroma.
Okay. So the deeper lymph node dissection is done. Any dreaded complication you anticipate?
Complication like we can expect like this one, sir. Erosion of the femoral vessels causing torrential bleed leading to the death of the patient.
Femoral blowout. How to prevent that?
To prevent that, like in the this one traditional technique is to this one sartorius transposition flap you will use, sir, to cover the femoral vessels.
It's called a sartorization.
Sartorization, sir, yes.
Okay. Any other technique is available for doing inguinal block dissection?
In traditionally, other technique is, sir, this one, sir. Modified catalonas, sir, catalonas.
What is that?
Catalonas, like only the dissection is limited, sir. There is in this case, in this technique, there is no GSV ligation, sir, and no sartorius transposition, sir. Only the important nodes, like only the superficial nodes, are removed in this case.
Okay. With the minimally invasive, you can do the inguinal lymph node dissection. Minimally invasive techniques.
Yes, sir. Laparoscopic, this one, sir. Nowadays, laparoscopic surgeons are doing.
Okay. What is the result? Difference between open and the laparoscopy?
Difference more like in this in traditional, like more like patients will be having lymphedema, sir. In these cases, the less chances of lymphedema for
Laparoscopy.
Laparoscopy, sir, yes. And the flap necrosis is not seen in this case.
It's not seen. The flap necrosis incidence might be low, but not completely.
Yes, sir, yes.
Flap necrosis is still seen in laparoscopy technique also.
Okay, sir.
patient says, I don't want surgery for the penile lesion now. What are the other options?
We can go for chemo radiation.
Because penis is one of those important organs. Probably, you deprive me of penis and sex in future. I think he'll. What he can do?
We can go for radiotherapy, sir, or this one, sir. Chemotherapy.
Radiation.
Radiation therapy. Yes.
What is the indication for radiotherapy in carcinoma penis?
Large tumors, sir.
Hmm.
Large tumors and extranodal metastasis when they are positive and not fit for the surgery.
Young patient who is not willing for surgery.
Yes, sir.
Small lesion.
Small lesions also. Yes, sir. Small lesions.
What type of radiotherapy is given?
Type of radiotherapy which you use.
Sir, pardon, sir.
No,
What is the type of radiotherapy?
Type of radiotherapy used in this particular case?
Type of radiotherapy.
There are different types, external beam radiation, like that.
External beam therapy and brachytherapy, sir.
Now, what is that brachytherapy? What do you do?
Brachytherapy, like small radium pellets will be there, sir, to be worn on the penis. 6,000 centimeters for the 7 to 8 days will be given, sir.
Yes. Chemotherapy for advanced disease?
For advanced disease, CIP regimen, sir. Cisplatin, paclitaxel, and ifosfamide.
Any role for targeted therapy?
Targeted therapy, no, sir. I don't know.
Okay. Time up, sir. Half an hour.
Yes, sir. Any other questions, sir?
Yes, ma'am is asking about reconstruction of the penis. If the patient wants this penis to be there even after surgery, is there a possibility of reconstruction?
Yes, sir. In the total penectomy, we can plan for radial forearm flap or anterolateral thigh flaps.
Okay.
Penile implants also are available now.
Yes, sir. Implants
that can be advised.
Prosthesis also. Yes.
Yeah, post-surgery.
When do you do more surgery?
When the lesion is small, sir, when the patient is young, sir, when the lesion is only limited to the glans or prepuce, sir, MOH micrographic surgery under the microscope we can do, sir.
Role of laser?
Yes, sir. Laser is also same,
laser.
Sir. Laser, young patient, smaller size, less than 2 centimeters.
What is the which laser is used here?
CO2 Nd:YAG laser, sir.
Okay, right.
Prognosis
any
of this
questions?
patient?
Sir, pardon.
Prognosis.
Prognosis, sir, prognosis is if the patient is distant, if he has distant metastasis, the prognosis is bad, sir. As the disease is very slow growing, sir, this one.
This is advanced disease already. Patient is having advanced disease.
Yes, sir.
What is important of HPV causing CA penis and non-HPV causing CA penis? It is important.
Yes, sir, it is important, sir.
Why?
HPV causing spread.
HPV related CA penis is more favorable prognosis than the non-HPV. That's really important.
Yes.
Okay, sir.
Okay, sir. We'll go to the next case, sir. Any other questions, sir?
Vaccination.
Has asked about vaccination. So I think probably vaccination of a woman now, which is national program, can probably reduce occurrence of CA penis in a male.
Sir, now for boys also they are advising, sir.
Yes.
2 doses, 9 to 14 years, 2 doses. More than 15-20 years, 3 doses is advisable, sir,
Yes, sir.
to prevent.
Yeah.
Okay.
Next.
Dr. Varsha,
Good evening, sir.
you are ready, no?
Yes, sir.
Okay, sir. We'll continue with the second case, obstructive jaundice by Dr. Varsha, third year PG from KMCRI, Hubballi. Yeah, please continue.
Sir, I've not been allowed to share my screen, sir.
Martin,
Done, ma'am. You can share it now, ma'am.
Mm.
Sir, is it visible, sir?
Yeah,
No, ma'am.
you're audible.
you are audible, but screen is not shared. Screen is not visible.
Else, shall I share it, ma'am?
Yeah, share. Martin, share,
Yes.
Martin.
Yes, ma'am. It's visible.
Oh, yes. Can I start, sir?
Yeah, continue, please.
Good evening, sir. I'm Varsha here, sir, third year postgraduate student from Karnataka Medical College and Research Institute. I'm going to be presenting a case under the guidance of Dr. Ishwar Usmani, sir, Professor and Head of Department in General Surgery. Here is a 53-year-old male patient by the name S, hailing from Dharwad, Karnataka, who is farmer by occupation. He gave a complaint of yellowish discoloration of eyes since 1 month and complaint of fever since 10 days. Patient was apparently all right 1 month ago when he noticed yellowish discoloration of the sclera, which was insidious in onset, gradually progressing. There is no waxing and waning, no aggravating or relieving factors. Patient also complains about fever since 10 days, which was sudden in onset, intermittent, not associated with chills and rigor, continuous, low grade, and relieves on taking medication. There is also a history of unintentional significant loss of weight since 3 months, which was approximately 5 to 6 kgs in 3 months. A patient also gives history of passing high-colored urine and history of passing clay-colored stools. There is no history of vomiting, no history of abdominal pain or abdominal distension or any abdominal mass. There is no history of pruritus. There is no history of altered bowel habits. There is no history of hematemesis or melena. There is no history of blood transfusions. There is no history of drug intake. There is no history suggestive of hemoptysis, respiratory discomfort, back pain, or bony pain. Past history. There is no history of previous similar complaints, no history of previous surgeries or prior hospital admissions or any comorbidities. Personal history, diet is mixed, appetite is reduced, bowel and bladder is regular. Patient is a known tobacco chewer since 30 years and a known BD smoker since 30 years who used to smoke 15 BDs per day. Family history, there is no history of similar complaints in other family members or no history of cancer-related deaths in the family. Sir, can I summarize the history, sir?
Yeah.
Yes. Here is a 53-year-old male patient who came with the complaints of painless, progressive jaundice since 1 month with history of fever and high-colored urine and passing clay-colored stools. These symptoms are also associated with significant loss of weight and loss of appetite. Sir, my provisional will be obstructive jaundice secondary to a neoplastic etiology, sir.
How do you explain fever now?
Sir, it can neoplastic etiology because of release of the interleukin 1 and 6 can also result in fever, sir. Or it can be secondary to any other infections also, sir.
Can there be cholecystitis there?
Sir, it can be, sir, but very less likely, sir.
Why?
if I'm suspecting it to be a neoplastic etiology, sir. But if it is secondary to a bile duct stone or choledocholithiasis, sir, there is a high chance of it being from because of cholangitis, sir.
The
What is
CBD
the
with cholangitis
reason for
is a
cholangitis
possibility.
here?
Sir,
Why there is fever in choledocholithiasis?
sir, because of bile stasis, sir, there is increased chances of bacterial proliferation in the bile duct resulting in infection and cholangitis, sir.
Why it is not present in malignancy? There is stasis here?
Yes,
No
sir.
doubt. And then
Yes,
why?
sir.
Because of stones.
Stone itself is a nidus for infection,
Yes,
sir. So,
because of stones.
yes, sir.
Okay.
What is the weight loss which he has told in history?
Yes, sir. Around 5 to 6 kgs of weight loss in 3 months, sir.
Just 3 months. Significant, not significant?
Significant, sir.
What is significant weight loss?
Sir, up to 10% of body weight in 6 months, sir, or 7.5% in 3 months, sir, or around 5 to 6% in case of a month, sir, and 2 to 3% in case of in a week, sir. Unintentional loss of weight.
Unintentional.
Yes, sir.
Okay. Proceed.
Yes, sir. On general physical examination, patient was afebrile. Pulse rate was 66 per minute. BP was 138 by 86 millimeters of mercury. Saturation was 96 at room air. Icterus was present. BMI was 21.1 and ECOG score was 1. There was no pallor, cyanosis, clubbing, lymphadenopathy or edema, sir. On abdominal examination, on inspection, abdomen was scaphoid, umbilicus was in the midline and inverted. There were no engorged or dilated veins or scars or sinuses. All corresponding quadrants moved equally with respiration. There was no visible fullness or lump noted over the abdomen. Renal angle was normal, and hernial orifices, including external genitalia, appeared normal, and there was no supraclavicular fullness noted. On palpation, there was no local rise of temperature or tenderness over the abdomen. Non-tender, were firm intra-abdominal and intraperitoneal globular lump of size approximately 5 × 3 cm was present in the lower part of the right hypochondrium, which was smooth in surface, rounded, well-defined margin. Superior margin of the swelling is not palpable, merging beneath the costal margin, which moves with respiration. And on percussion, it was continuous with the liver dullness. The lower border of the liver is palpable 3 cm below the right costal margin in the mid-clavicular line, sir. That was non-tender, rounded borders and surface is smooth. Spleen was not palpable and there was no other abdominal lump which was palpable, sir. On palpation of renal angle and left supraclavicular region, it was normal and external genital and hernia orifices were normal, sir. On percussion, there was no evidence of free fluid. There was no obliteration of liver dullness. Upper border was percussed at the 5th intercostal space and the liver span was about 12 centimeters, sir. Auscultation, normal bowel sounds were heard. On digital rectal examination, normal sphincter tone was noted. There was no fissure, fistula, or any skin tags. Mucosa was normal. There was no Blummer-Scherf notes which are palpable, and fecal staining was present, and it was clay-colored stools were noted. Systemic examination, cardiovascular, respiratory, and central nervous system examination were normal, sir. Sir, can I summarize the whole case, sir?
So the mass which you are able to palpate, what is it?
Sir, it is probably gallbladder, sir.
You are telling it is a gallbladder.
Yes, sir.
Okay.
Is there any intrinsic mobility?
Sir, it was we could move it side to side, sir.
Yeah, you did not mention that.
Moved with respiration, sir.
Yeah, it moves with respiration, no doubt.
Yes,
but
sir.
is there any side to side?
Yes, sir. Side to side mobility was present, sir.
You told you can insinuate your finger between the mass and costal
no,
margin?
Sir. No, sir. Superior margin, it was extending beyond going beyond the subcostal margin, sir. I couldn't insuate my finger, sir.
Yeah, is the liver tender to touch?
No, sir, it was non-tender, sir. Surface was smooth and it was rounded margin, sir.
Surface?
Surface was smooth, sir.
No.
And rounded edges were there, sir.
Yeah.
Okay. Proceed. No free fluid. There was no free fluid.
No, sir, no free fluid was present, sir.
Okay. Proceed.
Sir. Here is a 53-year-old male patient who came with the complaints of painless progressive jaundice since 1 month with history of fever, high colored urine and passing clay-colored stools. These symptoms are also associated with significant loss of weight and appetite. On examination, a 5 cross 3 centimeter palpable mass in the right hypochondrium, which moves with respiration, which is in continuity with the liver and with no evidence of metastasis.
What's your diagnosis?
The liver palpable?
Yes, sir. Liver was palpable, sir.
Is the liver enlarged?
Yes, sir. Liver was enlarged, sir. But
yeah, so you have to mention mass in the right hypochondrium.
Yes, sir.
Because it's coming below the costal margin, isn't it?
Yes, sir.
Definitely there is hepatomegaly.
Yes, sir.
Along with hepatomegaly, you have got one more mass, that is a probably globular mass, is gallbladder.
Yes, sir.
Yeah.
Sir, based on the examination till now and history, I would think it is an obstructive jaundice with a neoplastic etiology, sir. It can be either my first diagnosis will be a periampullary carcinoma, sir. Secondary, it can.
Okay. Second diagnosis.
It can be a cholangiocarcinoma, sir, and it can be a pancreatic head carcinoma, sir.
Okay. What are the components of the periampullary carcinoma?
Sir, it's a neoplastic etiology. I'm also suspecting, sir. So it is other
coming
than
under what
yes.
periampullary?
Sir,
what is periampullary?
Sir, it is a carcinoma which is within 2 centimeters of the ampulla of ureter, sir.
Okay, what are the components in that?
So it can be a distal distal bile duct, sir, common bile duct distal part, sir. It is a papilla per se, sir, of the duodenum, and it is the main pancreatic duct, sir. All these all carcinomas of all these regions will form the complex of periampullary carcinoma, sir.
Pancreatic duct or head of the pancreas?
Duodenum.
And head of the pancreas, sir.
And duodenum?
Duodenum, papillary and duodenal D2. Second part of duodenal carcinoma will also come under periampullary carcinoma, sir.
Okay, fine. Now what do you want to do?
Sir, I would like to, initially I would like to get blood investigations done, sir.
Okay.
Yes, sir, blood investigation has been done, sir. The total bilirubin was initially when the patient presented, it was 4.7 and direct bilirubin was 4.2, sir. Progressively with patient admitted also, there was progressive rise in the total bilirubin and the direct bilirubin levels, sir. And I would like to check is the alkaline phosphatase level, sir.
Okay.
That is also raised, sir. So because if that means it is a bile duct abnormality per se, sir.
Listen, it is initially it was raised, later
yes.
It had come down. So what are you thinking of?
Sir, that might have been the sloughing off of the. There'll be red.
Sloughing off of the tumor might be there.
Yes, sir.
Okay.
Because of the necrosis, sloughing off, there might be relief in the obstruction, sir. So.
Okay.
Yes, sir.
Okay. Anything else you want to look for?
Sir, I would also like to look at the liver status per se, sir. The transaminases to look at the liver status also, sir. Ideally, it should be below 40, sir, both AST and ALT, but here it is raised, sir.
What do you think?
Sir, since patient is a chronic tobacco consumer, sir, so it can be because of chronic liver disease, sir, or it can be because of increased bile. It can be a biliary cirrhosis also, sir.
Biliary?
Cirrhosis, sir. Cirrhosis of the liver, sir.
Why you think cirrhosis of liver?
Sir, because of increased bile, sir, there'll be more. It'll damage the hepatocytes, sir, and that is why they can be raised in the transaminases, sir.
No. In a obstructive jaundice, an obstructive jaundice, you have got elevated enzyme levels, no doubt. But significant is alkaline phosphatase or gamma glutarate transferase.
Yes, sir.
These are elevated, which are in favor of obstruction to the CBD due to malignancy.
Yes, sir.
Understand?
Yes, sir.
Alkaline phosphatase is elevated, grossly elevated, 490.
Yes, 700.
Yeah.
I would also like to look at the patient status also, sir. The nutritional status of the patient, sir. The total protein and albumin, sir. Here,
Yeah.
albumin is on the lower side, sir. It is 2.9 and is kept. There was a reduce and then again an increase is noted, sir.
It is significant.
Sir, patient, yes, sir. It is
His
significant. There has
BMI is
been loss.
21. His BMI is 21.
Yes, sir.
And he
Yes.
has got no other features of cirrhosis, like ascites is not
No.
there.
No, sir.
What are the features of chronic liver failure?
Sir, first is jaundice, sir. Yellowish discoloration of eyes, we note, sir. Then malar erythema, sir. And fetor hepaticus, sir. Spider nevi over
That is fulminant hepatic failure, chronic liver disease, you know.
Yes, sir. The spider nevi
Classical
over
cirrhosis.
Yes, sir. Spider nevi over the chest and neck, sir. Palmar erythema will be can be
Erythema.
noted. And in the abdomen, caput medusa can be noted, sir. Ascites might be present.
Ascites. Yeah. Is there any ascites here?
No, sir.
No.
There was no ascites, sir. And bilateral pedal edema can be noted, sir.
Okay.
Yes.
What
Given
imaging?
one choice, which investigation you will do? Apart from this.
Sir, blood investigation, sir.
No. Investigation in sense in the form
Yes.
of
Yes, sir. Next,
no,
I would like to
anatomical diagnosis.
ultrasound will be my first
Yes.
option.
Ultrasound. You have ultrasound report there?
Yes, sir. Sir, on ultrasound, there was hepatomegaly with intrahepatic biliary radical dilatation. CBD was dilated approximately 12 to 15 mm. Pancreatic duct was dilated. There was distended gallbladder and there was no obvious calculus, sir.
Okay. Now what?
Sir, pancreatic duct is also dilated and common bile duct is also dilated, sir. Since
Okay.
both are dilated, so I would like to go for a, it goes more towards periampullary carcinoma diagnosis, sir.
Okay. But they have not commented anything on the tumor or anything. It can be a stricture also, isn't it?
Yes, sir. Yes, sir. It can be stricture. Yes.
So what further imaging you want to do?
Sir, I would like to go next. I would like to for a non-invasive. I would like to go for a CCT,
Okay.
chest, abdomen, pelvis with the pancreatic protocol, sir.
Okay. What do you want to look for there?
Sir, I would like to look at the status of the biliary system and the pancreatic duct and the head of the pancreas, sir, because of my differential diagnosis, which I thought about initially, sir. If there is any pancreatic, sir, first initially I would like to look at the intrahepatic biliary radical dilatation, so whether it's mild, moderate, or severe, sir.
Intrahepatic biliary radical will be told in the ultrasound only.
Yes,
Okay.
sir.
I want to know in
yes.
CT scan what additional information you want to fetch, which is not available in the ultrasound.
Sir, whether it is a stricture or whether there is a growth in the periampullary area, sir.
Okay.
I would like to do that, sir.
Then, don't you want to look for the lymph node status, if at all
Yes.
malignancy?
Yes, sir. I would also like to know about the lymph node status, sir.
Don't you want to look for the local extension?
Yes, sir. Local extension of the tumor, I would like to know, sir. If there are met, sir, I would also like to look for the metastasis, sir. If there are any signs of metastasis, sir.
Okay.
Next,
Okay,
any other investigation?
CT
Sir,
scan.
yes, sir. It's done, sir.
What is it?
Sir, there is no evidence of metastasis in the thorax. Liver was normal in size and shows homogeneous parenchyma. There was no focal diffuse lesion seen. Gallbladder was over-distended, dilated, bilobar, IHBRD, CHT, CBD measures 14 was dilated. CBD measures 14 mm. There was tapering of the distal CBD with the wall thickening, which shows delayed enhancement, and there is no pericholecystic fluid collection. Spleen was normal in size and parenchyma. There was no intraparenchymal lesion seen. Pancreas shows normal parenchyma, no focal diffuse parenchymal lesion. Pancreatic duct is normal and there is no peripancreatic fluid collection. Kidneys,
Okay.
both the kidneys show normal
Okay.
size.
Fine,
Yes.
fine.
Yes.
It's a dilated CBD
Impress-
with of the
Yes.
distal CBD. Anything
Yes.
further you want to investigate the patient?
Sir, I would like to go for an endoscopy also, sir. Invasive, I would like to next opt for an endoscopy, sir.
Do endoscopy and do what?
Sir, I would like to see whether there is any growth in the distal, in the periampullary, sir. At the ampulla, I would like to see the status of it, sir.
Already you've got a CT scan done, isn't it? CT
Ye-
scan showing this picture. Again, what you want to see the photo? Is there any importance of endoscopic ultrasound here?
Yeah. Yes, sir. I would like to know about the thickness of the growth I'm suspecting, sir. What is the, for staging also it will be useful, sir, to know what is the thickness of involved walls, sir, of the growth, sir.
See, they have told intramural cholangiocarcinoma, isn't it?
Yes, sir.
So you can do an endoscopic ultrasound and see what it is. Can you take a tissue diagnosis from there?
Yes, sir. I can go for an endoscopic ultrasound biopsy also, sir.
Ultrasound, FNAC or a breast cytology. Under
Yes,
what
sir.
anesthesia?
Sir, just it's not required, sir.
Anesthesia is not required.
Just sedation is enough, sir.
Okay, maybe.
Yes.
What is the role of PET scan here?
Sir, to rule out metastasis, I can get PET
You can get a
scan.
metastasis workup beforehand, you know. Yeah.
Yes, sir.
Okay. Now everything is done. There is a tumor there.
Have you done endoscopy?
Yes, sir. It was done, sir. It showed on endoscopy there was first GERD with hiatal hernia and D1 nodular lesion, sir. On side viewing endoscopy there was a bulge from the ampulla, sir. Biopsy was taken, sir, and reports are awaited, sir. So there was an ampullary growth, sir.
How did you take biopsy? Side viewing endoscopy, isn't it?
Yes, sir. Side viewing endoscopy, sir.
Yeah.
The side viewing endoscopy. Correct.
Yes, sir.
Okay. Now you have got, what is the biopsy report?
Sir, reports are still not come, sir. We're suspecting it to be malignant, sir.
Okay, fine. Now there is a distal CBD growth. Distant metastasis, no evidence of distant metastasis, patient is fit, everything is done. Now what do you
Yes,
want to plan for?
Sir, based on the patient, I would like to do preoperative supplementation for the patient, sir. So I would like to improve the nutritional status of the patient also, sir.
How you want to improve the nutritional status?
Sir, I would like to add supplements like cholestyramine, sir, which will increase the fat absorption. They'll bind the bile salts and reduce the enterohepatic circulation of bile, stercobilinogen and urobilinogen, sir.
Okay.
And thereby reducing the bilirubin. So I would like to go for a supplement of fat soluble vitamins also, sir.
Okay. How long?
Sir,
What about prothrombin time?
Sir, yes, sir. I will based on the prothrombin time, if I'm suspecting there is if the prothrombin time is more, sir, then I would like to go for giving vitamin K, sir. I will opt to give vitamin K for the patient, sir. And I would also like to, based on that, I would also go for an FFP transfusion also, sir.
Okay. Now your patient is fit for surgery.
Yes, sir.
What do you want to do?
Sir, patient is fit. I'll explain the risks to the patient, sir. So, but before anything, sir, I would like to first go for a diagnostic laparoscopy, sir.
And do what?
To see the status, sir. If there is any metastasis that has been missed by.
You have got a PET scan only done. Everything is clear now.
Yes, sir. Then I would like to plan for a Whipple's procedure for the patient, sir.
Okay. Under what anesthesia?
Sir, under general anesthesia, sir.
And only?
General anesthesia with epidural for post-operative pain management, sir.
Okay, what incision?
Sir, Chevron's incision will opt, sir. Bilateral subcostal incision, sir.
What are the structures which you remove in Whipple's?
Sir, I will be removing the head of the pancreas, head and up to the neck of the pancreas, sir. I will be removing the distal 1/3 of stomach, sir, duodenum, and about 10 centimeter of the proximal jejunum, sir. and
Why?
the gallbladder and the
Yeah.
cystic duct and gallbladder, bile duct and the CBD, sir.
Why you want to remove the stomach there? Distal to 1/3 of the stomach.
Sir, here I can even opt for pylorus preserving pancreaticoduodenectomy also, sir.
Okay.
Yes, sir.
And how do you reconstruct?
Sir, I will go for a pancreatico-jejunostomy or a pancreatico-gastrostomy, sir, based on the condition of the pancreas, sir. And
Okay.
then I would go for a hepatico-jejunostomy, sir, and go for a gastro-jejunostomy, sir.
Okay. And would you like to do a feeding jejunostomy also?
Yes, sir. I will also opt for a feeding jejunostomy, sir.
Okay.
Yes, sir.
What is the complication which you anticipate here?
Sir, the risk of post-operative pancreatic fistula, sir. That is one of the risks. And anastomotic leak, sir.
Which can leak? Which is having a high risk of leaking?
Sir,
Hepatico-jejunostomy, gastro-jejunostomy, or pancreatico-jejunostomy?
gastro-jejunostomy, sir.
Gastro-jejunostomy will leak.
Yes, sir. The risk is, yes.
The risk is very high, is it? Could be. Okay. Now, this is about the patient is fit. If the patient is not fit,
Sir, I can opt for a chemoradiation, sir. Chemoradiotherapy for the patient, sir.
okay, there the patient is spiking also, no?
Fever, sir. Yes, sir. Patient is having increase in the bilirubin level, sir. So I can opt for an ERCP stenting of the obstruction, sir.
Okay. Now you have done ERCP, but you are not able to negotiate the stent only. It is a tight stricture. Now what to do? Is there any other option?
Sir, I can plan for only hepatico-jejunostomy also, sir.
And do what?
Sir, I mean, if I'm not able to place a stent, I can go for a percutaneous transhepatic biliary drainage, sir.
Okay.
In case the bilirubin is very high, sir, above 15.
Okay.
Any tumor markers you would like to do?
Sir, I would like to get to rule out. I can get CA19 and carbohydrate antigens 99 done, sir, and CA
rule
also
out,
done.
It is not to rule out. CA19.
Confirms.
Not to confirm, Baba. Prognostic value is for surgery by chance if the patient survives.
What is Gurubasavana's law?
Sir, when there is a palpable mass in the right hypochondrium with the jaundice, sir, it is very unlikely to be because of choledocholithiasis, stones, sir.
Yeah, there are exceptions to this rule, isn't it?
Yes, sir. Sir, when there is a double duct, so when there is a stone obstructing both the cystic duct and the distal and the common bile duct, sir, that is one of the exceptions, sir. When there is a mucosal of the gallbladder, sir, that can also be a
yes.
And when there is a cholang, yes.
Okay. When do you do just stenting for this patient?
Sir,
your patient is having a BMI of 21. What is this ECOG scaling?
Sir, one, sir.
Pardon?
One, sir. He's able to perform he's able to do self-care, sir.
Okay.
Perform daily activities, sir.
Why he is not having itching over the body?
Sir, the bilirubin levels are not that high also, sir. It is around...
Is it bilirubin which causes, or is it bile salt which causes?
Sorry, sir. Bile salt, sir.
Where is it deposited?
Sir, and the nerve endings on the skin, sir.
Nerve endings on the skin.
Yes, sir.
Nerve endings.
Yes, sir. Nerve endings. It will go and irritate the nerve endings, sir. So that is why there'll be itching, sir. Patient will develop pruritus, sir. That is one of the theories, sir.
Nerve ending, is it? Maybe.
Yes, sir. There is other theories also, sir, for why patient develops pruritus, sir.
Hmm.
The bile salts will go and stimulate the mast cells, which will result in regranulation and resulting in histamine release and resulting pruritus, sir.
Fine. Why there is high colored urine?
Sir, in obstructive jaundice, there will be increase in the conjugated bilirubin, sir. So that will get that will be excreted through urine, sir. That is why there will be high colored urine,
What
yellowish,
is
high
through urine?
urobilinogen, sir.
Urobilinogen is excreted through the urine.
Yes,
And
sir.
what is the reason for this clay colored stools?
Sir, because of obstructive jaundice, there is no conversion of the conjugated bilinogen to stercobilinogen in the intestine, sir. Because
Okay.
of absence of stercobilinogen, we have clay colored stools.
Good.
This gentleman has got cirrhosis also.
Sir?
This gentleman has got cirrhosis along with the periampullary cancer. So you want to do diagnostic laparoscopy.
Yes, sir.
How will you proceed?
Before doing it, I would like to give preoperative.
Yeah, vitamin K, you are supposed to give vitamin K. Then
Yes, sir.
important precaution, especially whenever you put a trocar.
Sir, I have to go for a lower level of the trocar because of hepatomegaly if I'm suspecting, sir.
No, that's a higher up, isn't it? You will be going low down. But
yes, sir.
More important than anything else, especially whenever it is cirrhotic and portal hypertension.
Portosystemic shunt around the umbilicus, sir.
Correct, exactly. Okay, that measure has to be taken.
Yes, sir.
Okay, right.
Role of neoadjuvant chemotherapy?
Sir, if it is the patient is not fit for surgery, sir, then I would like to go for chemoradiation therapy, sir. I would like usually capecitabine with cisplatin is the preferred chemotherapy, sir, which I can opt for the patient, sir.
Okay.
Sometimes even FOLFOX regimen can be also followed, sir. With the radiation therapy, if it can also be opted, sir, if I'm going for a palliative treatment, sir.
What is the access loop in surgery?
Sir?
What is access loop in biliary surgery?
Heard about? There can be multiple stones in the liver itself.
Intrahepatic biliary stones.
Yeah. Heard about it? Access loop?
No, sir.
Okay, sir.
Homework.
So any other questions, sir?
No.
Buddy, any questions?
No, sir. Good.
Thank you, sir.
I think
Yes.
probably if there are no questions and if we think that time is up,
Yes, sir.
Madam, can we call
Dr. Sarvesha, sir?
Yeah. Sir, you can just answer about that access loop, clarify her doubts.
I don't want to tell, madam.
Yeah, let them read.
lot of postgraduates are now. Yeah, 44 participants are there. So
Good.
I'll give them. It's given in Ferguson.
Yeah.
So find out.
Anyone can answer if it's there.
Yeah.
PGs.
Mhm.
Any postgraduates can answer. I think both the students have done. I think up to the mark.
Yes.
Let me congratulate both of them for their good performance.
Thank you, sir.
And I thank ASI Karnataka State Chapter for appointing me as examiner today. Hope I have done my job neatly. Thank you very much for giving me opportunity. Thank you each and every one of you.
Thank you, ma'am. Thank you, Naaz ma'am, for giving your opportunity.
Yes.
Thank you, Sarvesha, sir. Thank you so much.
Dr. Sarvesh?
Sarvesha, sir?
Okay.
Manas?
Yeah,
Okay.
Dr. Both
Okay, I'll
Dr.
only.
Varsha- yeah, Dr. Sarvesh is here.
Sir, left
Not
hand.
us. No.
Yeah,
Left
yeah,
hand.
Dr. Sarvesh and Dr. Varsha and Dr. Afsar, both of you did extremely well. So, and I would like to thank Dr. Gopinath Pai and Dr. Likith Rai for being the examiners today. And Dr. Anand Kumar has also done a very good moderation. And to all the postgraduates, I would like to say that we had one session last month on how to present a paper and how to win an award paper. So we have shared the link for that YouTube recording on KCSI, www.kcsi.com. And you can get that link in the Zoom. I have posted it just now. You can just save that link and then go to that and see how you can present even better than what you did today. I must say that both of you have done extremely well. Congratulations to both of you. And I also thank all the people who have participated today and given a valuable contribution. And kindly, Dr. Sarvesh is not there. Anybody to give the vote of thanks?
I'll only give it.
Yeah, please.
Yeah.
Yeah,
Okay.
go ahead.
Okay, I'll thank Dr. Naaz Madam and Dr. Sarvesh Rajaras, Dr. Rajshekhar Jaka, and our treasurer, Dr. Gurubasavana, Dr. Srinivas Pai, and our examiners, Dr. Gopinath Pai, Dr. Likith Rai, and all our national EC members, state EC members, consultants, HODs, and PGs for attending this PG time program. I once again thank all for attending the program, and I ask all our PGs to attend the next PG time as well as the present time program. Every Thursday it will be there. We'll post in the all HOD groups as well as PG groups whenever the program is there.
Thank you.
Okay,
Thank you.
madam. Thank you.
Thank
We'll
you
wind
all
up the
and good
program.
night. Yeah,
Okay.
thank you. Thank you.